Unfortunately, back pain is not a diagnosis, back pain is a symptom.
What's the difference between a normal GP and a GP that specializes in workers' comp and CDP?
I get that a lot.
Essentially, it sounds like just education, and then negotiations and mediation.
Most of my role is just purely to educate one around about the scheme, what they can and cannot access, and what they can and cannot do. I do get patients who come to me asking me for help, and when I investigate further, the injury was related to non-work related activities. That's the biggest issue I believe that most insurers have.
Why is it that doctors just can't communicate?
A lot of time, I get diagnosis being left blank. Then there's no working diagnosis, so I have no idea what I'm doing. So that's why I see my role very important, because we need to help these patients recover to the best they can.
Before we begin, can I have a minute of your time? In Australia, every few minutes, someone gets injured at work, on a work site, in a warehouse, on the road, and in an office chair that they've sat in for over 10 years. And most of these injuries, they were preventable. Our podcast exists for one reason: to have an open conversation about work, safety, and our compensation system. We talk to experts in our field to discuss the good, the broken, and what to improve within the system. Because safety isn't paperwork, it's people, it's the family, it's our future. So if you learn something new from this episode, make sure you subscribe to the AusRehab podcast. And if you or someone you know has a powerful story about injury, recovery, workplace safety, or any related topics, reach out to us. We're always open to guests who move this conversation forward in Australia. Now, let's get into today's episode. Today, we're joined with a extinguished guest, Dr. Danny Tang.
Thank you, Stephen.
I do believe it's one of the first podcasts that he has ever been in, and it's probably also the first doctor that has ever been on a podcast, especially in occupational health.
Mm-hmm.
But anyways, his credentials are extensive. Been in workers' comp CDP for 20, 30 years?
Yeah, over about 30 years.
30 years.
Yeah.
And then he's also IMC and countless patients in the past however long. And but today he joins us to have a chat.
Great. Thank you for the invite.
Awesome. So for the audience that don't know you, which I don't think there's that many, but tell us your story. Like, what's your background?
Okay. So I've been working in the industry now for the past 30 odd years. Straight out of the hospital, went straight into general practice and found a love for occupational health. And I've been doing work cover or occupational health and motor vehicle accidents and I guess public liability patients now for the past 30 odd years and enjoying it quite a lot.
You have your own practice, your own clinic?
Yes. So our practice is in Blacktown and that's where we see most of our patients physically. We also see patients via telehealth. And yeah, we've been doing this for quite some time now. When the practice first started off, the practice over 14 years ago, we've actually been doing telehealth for the past 14 years, not since COVID, but actually for the past 14 years since we've been open.
Roughly how many patients do you go through each year?
Ooh, that I don't know, but we do have. Practice is quite busy. I'm fully booked out most of the times, Monday to Friday. Don't have much time. I don't actually know the number of patients, but we do see quite a lot.
Okay, all right. I guess the number one question will be on my mind is what's the difference between a normal GP and a GP that specializes in workers' comp and CDP?
Yeah, I get that a lot. A lot of patients believe that their GP can best help them with work cover, and they can. The medicine in work cover is quite straightforward. It's not difficult. It's quite straightforward. The biggest part of work cover would be the administration and the legislation part, where most GPs may or may not fully understand. Like I said, I've been practicing for the past 30 years. I've learned a lot about legislation. I've learned a lot about how work cover system works, the CTP system, and the legalities behind that. Unfortunately, for a full-time GP who does what we call mainly non-work cover or Medicare work, they may not fully understand that. And that's where the difference lies. The insurance companies may or may not understand that. They treat every single medical practitioner the same. But yeah, the biggest issue is the administrative part of what they call a nominated treating doctor, and the roles of a nominated treating doctor under the work cover scheme, under the CTP scheme as well. But that's the biggest issue. Most GPs will know the medicine. The medicine's not hard at all. It's the administrative part that sets us apart.
So, okay, let's unpack that. Which part or the
Okay, so I guess the biggest role that a normally treating doctor needs to understand is simply writing the work cover certificate or the certificate of capacity.
Yep.
Yeah, the biggest issue that insurance companies have, from what I perceive, is what they believe in terms of what's written in the certificate. A lot of GPs or non-work cover GPs don't fully understand the certificate. If you go through each individual step of the certificate, you can actually break it down. Like for example, the diagnosis section. That's the biggest issue I believe that most insurers have. Most doctors don't write the diagnosis properly. Most of them only write symptoms.
What do you mean? Go.
Well, like for example, I see, as an IMC, I see a lot of certificates. The insurance companies will ask me to assist them with certificates. And the first thing as a work cover doctor or an IMC will look at is a diagnosis. Some doctors will write back pain, and that's it. Unfortunately, back pain is not a diagnosis. Back pain is a symptom. And that's the biggest issue I believe that the insurance companies have. The doctors normally treating doctors needing to understand the difference between a diagnosis and a symptom. You need to also provide a diagnosis as per what they call the work-related injury. So someone that develops back pain, depending on what the cause is, the diagnosis needs to be related to the work itself. Otherwise, it's not a recognized diagnosis, and you can't treat that.
Okay, there's two parts I want to understand. One is, what is the definition of a diagnosis, and what is the definition of a symptom?
The legislation, they term it Section 9A, talks about the diagnosis. The diagnosis needs to be related to the workplace, and it needs to be what they call a substantial contributing factor to the workplace. And like, for example, someone who lifts something heavy from the ground up, developing back pain, and let's say, for example, they have a lumbosacral disc protrusion compressing onto a nerve root. That's a diagnosis. That's a work-related diagnosis. However, if you find degenerative changes on there, then the degenerative changes is not a diagnosis, and you can't treat the degenerative changes. You can only treat the diagnosis that's related to the actual injury itself.
Okay. And what's the common mistakes for most other doctors that you see?
Like I said, well, back pain is such a common, I guess, injury that we see. And the biggest issue, I guess, I have as an IMC, and also what the insurance have, is the fact that doctors write down the word back pain or pain, or even worse, they leave the diagnosis blank. And most patients don't realize they see their treating doctor, who I guess don't see a lot of work cover patients. And the first thing that you need to understand is you need to have a proper working diagnosis. And without that, it's very difficult for the insurance company to approve, I guess, rehab, physio, psychology, or anything that's related to the claim. So when they do see the treating doctor, if the treating doctor can't first bypass the barrier of the diagnosis, it makes the claims process a lot worse. And that's why I guess most patients come and see myself asking for assistance, because the insurance company continues to decline services that the treating doctors ask them for.
Okay, hold on. That sounds interesting, because you're saying patients come to you after they've seen their GP.
Yes.
Is that common?
Yes. I get a lot of referrals from GPs and also patients, because they're getting frustrated because the insurance companies will decline physio and they can't understand why. And then the first thing I look at is the diagnosis, and okay, well, your treating doctors put down back pain. That's not a diagnosis, and hence the insurers may not understand why they're being referred for, say, a physio or a chiro.
Oh, that's interesting. Okay, so diagnosis is probably like one of the most important parts of the SEC.
Yeah.
What else is important?
Well, the second part of this figure also talks about the date of injury. That's quite important as well. And again, a lot of non-work cover doctors may not fully understand the term date of injury. So it's quite obvious. Like, let's say, for example, if I see a patient yesterday or today, and yesterday they lifted a box, heavy box, they developed back pain, that's very straightforward.
Yes.
We can say the date of injury would be, I guess, yesterday.
Yeah.
Now, we can also have patients who come and see us and they have no idea it's a work-related injury. They'll come and say, look, I've been developing back pain for the past 5 years. And I say, okay, that's fine. What is it that you do for work? You know, I sit at a desk all day. And they can't understand that, or they don't understand that prolonged sitting at a desk can cause back pain. Now, the date of injury is quite hard to say because, hey, I've been working as a receptionist for the past 5 years. What's the date of injury? There's a thing called Section 15 of the Act that talks about a date of injury. The date of injury now becomes a date when we first discovered the diagnosis as related to the workplace. So let's say, for example, today, I see you today and you tell me 5 years ago, or for the past 5 years, you've been working as a receptionist and your lower back pain is progressively getting worse and worse and worse. The date of injury will therefore be today. Mm-hmm. And again, unfortunately, a lot of doctors don't realize that the date of injury can be provided from the date at which the diagnosis was established, or the date at which, we realize what the diagnosis is. And Section 15 also talks about, in extreme cases, the date at which the person passed away. That can happen in severe cases as well.
What do you mean?
Like, for example, asbestosis. Asbestosis can take many, many years, say 10, 20 years to develop. And if they, let's say, for example, unfortunately, if a patient dies of, a cancer, mesothelioma, as a result of the asbestosis, at the date that we discovered that, hey, 20 years ago, 30 years ago, they worked in the industry where they were exposed to asbestos, the date of injury could be also the date at which they passed away.
Oh, wow, I didn't know this.
Yeah. The other thing also that's very important is the date of injury also stipulates what the insurance company approves. There's a thing called Section 60 of the Act. Section 60 talks about pre-approved services. Now, let's say, for example, a very common misconception is in regards to referral to specialists. A lot of patients will come to me and say, look, the insurance companies decline my specialist. They won't approve specialist review. What they don't understand is that what I guess most non-work cover doctors don't understand is that you don't need approval to see a specialist within 12 weeks from the date of injury. That's why the date of injury is so important. So if I see a patient, say 11 weeks ago, I can refer to any specialist of my choosing, and that's pre-approved. We do not require approval from the insurer. And most people don't know that. And that's why I guess where doctors like myself who work in the industry understand that we can expedite services very, very quickly.
Is there anything else for other specialists, as in like say physios and all that stuff?
Again, a lot of patients will say, my insurer won't approve physio. Or Section 60 says physiotherapy or allied health services are pre-approved. Within the first 12 weeks, they get 8 sessions. There is no need for an approval. There's also no need for a referral to see any allied health provider.
Any?
Well, I guess within the scheme, any physiotherapist who's accredited, any psychologist, any counsellor that's accredited, you do not need approval within 12 weeks from the date of injury. Again, that's why the date of injury is so important.
Wow. Okay. Apart from these two, like any other important things to look out for on a COC?
Yeah, still on page 1, and I believe it's section 2 or section on page 1 where it says the mechanism of injury. A lot of doctors leave that out. The mechanism of injury is actually very important. It needs to be specifically related to work. If it's not related to work, then there is no claim. The legislation stipulates that employment must be a substantial contributing factor. And I see that a lot. The mechanism of injury is almost always left out. And again, that would slow the process, delay the process of, I guess, approvals, delay the process of the insurance company accepting the claim.
Would it actually get the claim denied if it's
yes,
filled out?
Most definitely.
How?
Because employment needs to be a substantial contributing factor. That's a very important test. So if you say that I was gardening at home and I lifted a rock and I developed back pain, employment's not a substantial contributing factor in this case. It's the work at home.
Have you actually seen that happen before?
I have. On numerous occasions. I do get patients who come to me asking me for help, and when I investigate further, the injury was related to non-work related activities. If it's not related to work, we cannot put in a work cover claim.
Okay, cool. We should go down the list of that
Actually,
entire
we should.
COC. Yeah,
Yeah, if we have a
because this is a very cool topic.
we can talk about the first part. So section 1. Section 1 where it says injured person's consent. A big I guess issue that most patients, doctors don't really understand is if you read it, it actually says, I consent to my treating medical practitioner, my employer. Now in brackets, it actually says optional CTP claims. So a lot of patients don't realize that as the certificate itself, certificate of capacity, encompasses both work cover and CTP.
Yes. But this is only New South Wales though.
Correct.
Yes.
So in a work cover sense, you need to consent to your employer because the employer is actually who's the one who's paying for it. They pay the premium.
Yeah.
But what they don't realize is under CTP, they do not need to they need to consent. A lot of people actually don't read this, and I guess a lot of treating doctors also don't understand this. If you read it, it's actually on the certificate. It actually says optional for CTP claim. So if you're involved in, and I'm digressing here from a CTP claim, but if you're involved in a motor vehicle accident, you do not need to provide consent for your employer to actually know about your health services.
Yeah, no, we see that a lot here as well because some people go through the CTP, they don't want their employer to know what their what injuries they have.
But they sign it. And then I also advise them, you don't need to if you don't want to.
Yeah. And it's sometimes it's bad because I've seen people whereby they've contacted their employer and then because the CTP is not related to work, they can get let go of. As in they can get fired because they have an injury and they can't go back to their pre-injury duties.
Correct.
And it's very sad when that happens. Very sad.
Unfortunately, that happens. So if the patient cannot work return to work under full duties under the CTP scheme, the employer has every right to do whatever they need to do to protect themselves. Unfortunately,
yeah.
But the patient is protected. So again, we're digressing in from work up to CTP, but if you're involved in a motor vehicle accident, whether you're at fault or not at fault, you're entitled to at least 12 months worth of medical services and 12 months worth of wages. And that hopefully can cover the patient enough for them to actually recover and also seek employment services within the 12 months.
That's cool. Do you see many CTP patients yourself?
I do.
Like, what's the ratio between workers' comp and CTP for you?
It's hard, but if I was to estimate, I would say 80% work covers, 20% CTP.
Oh, how come?
No, very hard. I don't know. I guess it's. I guess I did look at the statistics previously. There are a lot more work cover injuries than there are CTP. I believe the ratio is probably about 60 to 40, or maybe 70 to 30.
It's not that, I think
cover,
so too, yeah.
So there's a lot less CTP patients out there than work cover. So that could be another reason.
Okay, so it's not that you prefer workers comp more than CTP. It's just that
our practice looks after both work cover and CTP, and also non-work cover, non-CTP, such as public liability cases. We look after everything.
Tell me about that a little bit more, because I actually don't know anything about public liability. Like my specialty is CTP and it's workers comp. Like, what's the difference between public liability and the other two schemes?
That's hard for me to understand. So I don't really understand public liability because I probably see about 3 to 5, maybe 10 a year at the max. Unfortunately, from what I know is the public liability insurers usually don't pay anything up front. And they usually pay everything on the back end. So unfortunately, literally every single public liability patient would require a solicitor system because it's actually quite difficult to understand. And like I said, I don't see that many, so I haven't followed up on what the legalities are. Yep. But what we do know is most public liability patients do not get the services that they require and the care they require upfront.
Oh, wow.
It's almost always a compensation scheme that they get compensated at the end. So they will have to pay for all their treatment services up front. 12 months later, 2 years later, their solicitors assist and they get their compensation.
Lump sum.
Yeah.
Oh, okay. Didn't know. Never worked in it.
It's not that. It's not. We don't get that many patients, so it's very hard to understand because I don't actually follow up that much on it.
Okay. All right. Let's go back to you then. Day to day, what does your day look like?
basically it's very busy. You know, by the time I wake up at 7 a.m., I literally start work. So the work consists of mainly emails, and a lot of emails, a lot of communication, a lot of reports, a lot of return to work plans. There's a lot of administrative work with work cover and CTP. And again, getting back to the treating doctor, the nominally treating doctor who are non-work cover patients, because they're so busy with their other patients, it's very difficult for them to actually respond to the emails, respond to reports, and respond to return to work plans by rehab providers.
Well, hold on. You say you wake up at 7:30 and start working. When do you stop working?
Again, probably stop working by 7:30 at night,
At
maybe
night.
even longer, because again, the volume of reports that we do is just quite extensive, and it was just we need to do. Well, to fulfill your role as a non-treating doctor, your responsibilities are administrative work, which is doing reports and return to work plans and responding to emails as soon as possible. And I guess the benchmark is 10 working days.
Okay. Hold. Like it seems like you know the dates. Back of it comes naturally. The dates. Do you actually remember all these?
Most of them.
Most of them.
Yeah. So I remember most of them. So we try our best to respond as soon as possible to insurer requests, because again, the quicker you respond to a request, the sooner the insurer will either approve or decline a claim, and approve or decline a service. And that's again, going back to the distinction between a work cover doctor and non-work cover doctor, is the non-work cover doctor may not find the time because they're very busy with their practice. There's a lot of work under their Medicare patients, so that they may or may not respond in time. If they don't respond within 10 working days,
what happens?
The insurers can take action.
Like what sort of actions?
Well, one of the actions is a referral to someone like myself, an IMC.
Okay.
And then the other action is a referral to an IME.
Tell me, okay, for the audience that don't know the difference, what's the difference between IMC and IME?
Well, an IMC, both IMC and IMEs are doctors. IMEs, you need to be a specialist. So you need to be like an orthopedic surgeon, a psychiatrist, an occupational physician. An IMC, like myself, I'm a facilitator. So my role is to help patients, help employers, help insurers, help rehab providers to get the best work outcome possible and return to work outcome for the patient. So help speak to the non-treating doctor. So I guess I'm an educator. So when I do call GPs, I try to educate them in regards to the work cover system, the work cover scheme, and then try to negotiate the best outcome possible for the patient.
So is that like a negotiation on a medicine base?
Both. So I comment on both the medicine and I also comment on the return to work and also the administrative components of the scheme.
Medicine and the legislation parts.
Correct.
Ah.
Yeah. So my job is to help treating doctors, employers, physios, anyone involved in the scheme to help the patient recover as much as possible.
Is that your purpose? Like helping patients recover as much as possible?
Correct. So the idea is to improve the patient such that they recover so they can return back to their pre-injury duties to the best of my abilities. I can only do so much. As an IMC, I can't treat. I can't offer treatment, but I can suggest to their treating doctor, this is what I may suggest treatment, or I may suggest this type of investigation such that we can clarify the diagnosis.
Here's a question. In your, the history of that you've been a GP or an NTD, how many of your patients recover, back to their work or something, in their lifetime?
Anecdotally, for my case, I guess I probably have up to about 80 to 85% of my patients return back to work to their pre-injury duties.
PID?
Pre-injury duties.
Wow. So there's a small part that goes back to like suitable duty or something.
Well, the other 15% never recover. So they either have what they call permanent modified duties, and I believe that terminology is not used anymore, but they return back to work with permanent restrictions. Yep. And you have some patients who can never return to work, unfortunately.
But that's only a 15%.
It's a very low percentage, correct.
Oh, that's cool. That's really cool. And in your life as an IMC, what's the most common mistakes you see doctors make?
Well, when I first get a referral, so I should say what constitutes a referral to an IMC. So,
that's cool, yeah.
so anyone can refer. So
Anyone?
Yes, anyone. So a rehab provider can refer to an IMC. An employer can refer to an IMC. Even the nominally treating doctor. So
how do they refer? Like just an email to an insurer?
Yes. So they write to the insurer and they say, listen, I need assistance. I need help. Can you please refer this patient to an IMC to look at the claim and see what we can do to help the patient recover? But generally speaking, it's the insurance companies that refer most of the work to me.
Why is that?
It's the insurance companies that fully understand why they need to recover, help the patient recover. And I guess the biggest issue that we have, or that I see, is education. Is doctors, nominally treating doctors, again, non-work cover nominally treating doctors, do not fully understand that they can actually refer to an IMC for further assistance.
Well, hold on. You mean the doctor essentially saying that, hey, this is out of my league kind of thing? Let's get an IMC involved.
Yes, they can ask for my involvement, and then I can come in and I can assist them as best I can by talking to the rehab providers, talking to the employers, talking to the physios, talking to anyone that's within this work cover scheme to assist the injured workers recover as much as possible.
You didn't mention injured workers, so you don't consult with the injured worker at all
in
the process?
It depends on the different staging. So there's stage 2 IMC where we only perform file reviews. So I'll review the file, I'll speak to the treating doctor, I'll speak to the physio, I'll speak to everyone involved in the claim, and occasionally we may or may not speak to the injured worker. Then there's a stage 3 IMC review, which means that the patient actually comes and sees me physically or via telehealth. In that case, I speak to the injured worker directly.
Okay, let's go back. In what circumstances should people refer to IMC?
Well, if they find that the injured worker is not progressing. So again, let's go back to back pain. So after 6 weeks, if the patient's not progressing, the back pain is not getting better, the capacity hasn't increased, then anyone within the scheme can refer to an IMC.
Oh, okay. And
anyone. Even the physiotherapist. So a physio can refer. A psychologist can refer.
I actually didn't know this. Yeah. Because I know rehab can do it. I know insurance can do it. I didn't know literally anyone can do it.
Yes, anyone within the scheme can refer to an IMC for assistance. And that's what we're here for. My role is to assist the injured worker recover by speaking to everyone involved in the case.
Then help me understand, like in the IMC process, what are procedures? What does the once you get the referral from whoever it is, like what does that look like afterwards?
So once the insurer gets the referral, so anyone can actually request the insurer to refer, or they can even.
So you submit it to insurer and then they'll do it. Yep.
So there's a guide called Standards of Practice. Yep. So there's a standard of practice stipulates what the insurer needs to do prior to the referral. I believe it's Standard of Practice 10.1. So what happens is that the insurer first needs to speak to the nominally treating doctor to ask, hey, what issues you have? What issues can we help try to resolve? So let's say, for example, the patient with lower back pain after 6 weeks can't return to work. That's the issue. There's a barrier that's stuck. The insurer needs to talk to the nominally treating doctor to try to resolve these issues. So if they can't resolve these issues, then they can say, hey, listen, we would like to refer your patient to an IMC. They'll need to document that, and they'll need to actually let the nominally treating doctor know.
Can a doctor say no? As in the NTT say, no, I don't want it?
That I've never met a nominally treating doctor say no, they do not want it. Most of the time, they won't even know. So unfortunately, with the standards of practice, the insurance company needs to actually inform the nominally treating doctor within 5 working days of the referral. Unfortunately, the compliance rate of that is actually very, very low. And I guess a lot of treating doctors don't know that. But so any referral to an IMC, the nominally treating doctor needs to be notified within 5 working days. Mm-hmm. The injured worker needs to be notified if they would like to participate in the case conference prior to a referral to an IMC. And the injured worker needs to either accept or decline the case conferencing, so to speak, between an IMC and a nominally treating doctor.
And can anyone decline then? to essentially
Oh,
stop the
yeah.
process?
So if a patient declines the case conference, that's fine. We can still go ahead. If the patient wishes to be involved, then what I would do is I will ring the injured worker, I'll ring the treating doctor, and I'll have a case conference with them. And I'll try to, I guess, resolve whatever issues they have and determine what we can do to best get the best outcome possible.
Okay, commonly, I'm assuming that diagnosis is like the biggest issue that you guys have.
Correct.
Is that
correct?
Yeah?
Because you need a working diagnosis. You don't have a working diagnosis, you can't
Just nothing
treat.
works. Yeah.
You need to know what you're working with, what we're doing here. And so unfortunately, also when I speak to treating doctors, they encompass back pain as a whole. They would say things like, this is my patient. He has type 2 diabetes. He has rheumatoid arthritis. So all these may contribute to the back pain. So I'm going to treat my patient as a whole. And I get that a lot. And unfortunately, that's not correct. The insurance company will only pay for the treatment of the back pain that's related to work, which is related to, I guess, where we go back to lifting a heavy object from the floor. But treating doctors may not fully understand that. And being GPs, would treat their patients as a whole. But they need to understand they can't do that. They need to actually segregate and separate that.
Oh, okay, that's cool. So diagnosis, big contention.
Oh, that's a big thing. That's what I look at always when I first get a referral. Yeah, I look at this. I look at the diagnosis. So I know what I'm working with. Sometimes, and a lot of time, I get diagnosis being left blank. Then there's no working diagnosis. So I have no idea what I'm doing. When you ring the GP, they have no idea, and they have to literally look up the notes and go through it. That's why the certificate of capacity is so important. It actually tells everyone within the scheme what we're working with. We need to know what we're working with.
Okay. First is diagnosis. What else? Well, what's the second part that you usually do?
Well, the mechanism injury. So again,
Okay.
most treating doctors can't substantiate the mechanism injury, and this can lead.
Why is it so difficult? Is it because the question is difficult or the term is difficult?
I don't know. I guess non-work cover treating doctors, when they treat a patient, like for example, type 2 diabetes, they just treat it. They just need, I guess they know the cause of the type 2 diabetes, but they actually treat the type 2 diabetes. They don't need to worry about anything else. In med school, we were never trained with this. We were only trained with the medicine. We were never trained in regards to the work cover scheme, how to write a certificate, and what's important in the certificate. So I guess I can bring that down to, we were never trained to this. That's why I say education is so important for everyone within the scheme, so we understand what we're working with.
Hold on. Like, in your opinion, though, then should med school incorporate a course or something that's specifically for workers' comp?
Most definitely. That's what, from that point of view, I definitely say most definitely. But then again, when you're going through med school, you're not actually working within. You're not actually trained to become a GP. During general practice, you're trained with all aspects of medicine. But unfortunately, in GP training, they also don't get trained in work cover. There was very limited education in regards to the GP registrars going through the system in regards to work cover, work-related injuries, and this type of scheme.
In your opinion, then, okay, let's go into that med school before we go back to the IMC stuff. If you were running the med school, say you're like the counselor of the
dean, I guess. Well, so
what would you make sure the curriculum has to make sure that you're a good workers' comp doctor, or at least somewhat proficient?
I guess I'm quite biased. I mean, my specialty and what I do day in and day out is work cover and CTP. So I guess everything I incorporate would be that. I guess if I was on the panel, I would at least suggest have 1 day a week's worth of training in regards to the work cover scheme, because the work cover scheme in terms of monetary value is quite significant. I guess I don't know the full percentage, but I would say at least 20 or 30% of the actual the health
funding.
budget.
Yeah. Is work cover in CTV?
Yeah, I believe so. There's especially for New South Wales.
Oh, what about other states? Do you know?
That one I don't know. I do look after other states. I do look after mainly Queensland, but I haven't got into that.
Okay. Anyways, that's fine. So essentially 1 day a week that you would suggest med school to incorporate.
Well, not med school. So when you go for your GP training as a GP registrar, they should at least have that to help doctors understand what to do.
That's cool. Anyways, going back to IMC. So diagnosis, mechanism of injury. Mm-hmm. What else do you look for?
And then in regards to what other services that the the patient can actually be eligible. But like for example, treating doctors don't fully understand that they don't need a referral to see a specialist within 12 weeks of the injury. They don't need a referral to see a physio. And again, one of the barriers is they say, so I'll speak to a treating doctor and he'll say, I can't refer to a physio, they're not approving physio. And then I'll have to explain to them they don't need to approve. It's actually pre-approved. So treating doctors that don't know this is a barrier for the patient because the patient has delayed treatment and hence delayed recovery.
Oh, and it's very common.
Oh, it's very common. Even the physio. So even CERA-accredited physios, CERA-accredited providers do not fully understand that. So every single allied health provider, to my understanding, is eligible for at least one treatment services, no matter what stage of the injury they have.
This is only New South Wales though, because
Correct,
I'm actually aware of that. That clause as well in the regulations. That's cool. Okay, treatment fourth. Like, what if you go down the list, what are the next things that you look for?
I guess return to work, suitable duties, and I guess the second part of page 2 of the certificate, filling out the capacity for activities. The biggest issue that most insurers have is that the treating doctors don't fill out the capacity for activities. So what they say is that if my patient is unfit for work, I do not need to fill out the capacity for activities, which is untrue. The only time you leave the capacity for activities blank is when the patient is fit for full duties. Any other instance, they need to fill out the capacity for activities. The capacity for activities is actually quite important because we need to understand how long can the patient stand for, sit for, push and pull. So that helps the insurer, helps the rehab consultants, and helps everyone within the scheme to know what the capacity is and what type of work or suitable duties the employer can actually provide.
Common mistakes in that section for most NTDs? Leaving
blank. So leaving the capacity for activities blank, not knowing that they can only leave it blank when the patient is fit for full duties. In all other instances, they need to fill it out.
Okay, like any mistakes that they make when they are filling it out then?
Well, the mistakes they usually have is they will say the patient can only sit for 20 minutes. However, the driving restriction, they can drive for an hour. So if you can sit for 20 minutes, you can technically only drive for 20 minutes.
Technically, yeah.
So it may mean that they're not aware of this, or they may be careless in regards to filling this out. But that's a very common mistake because it becomes confusing. Because how can someone sit for 20 minutes but yet drive for an hour? But like I said, the capacity for activity is actually very, very important because again, it allows everyone to understand what capacity the patient has in regards to suitable duties. Because in the long term, we need to try to get the patient back to work as soon as possible because we know short-term, long-term, benefits of work far precedes anything else, any other treatment. So because you improve the patient's mental health, going back to work,
society, like connection with society, all that stuff.
Yeah. So that we know that based on that evidence, you have much better outcomes.
That's cool. On that point, though, I've asked all my guys this specific question, as in what question do they want to ask Dr. Tang? Because they know they're here. You're here. The one question that pops up every single time is, what is suitable duties?
Oh, okay. So there's a section of the Act, Section 32A, talks about suitable employment. I believe the certificate actually stipulates suitable employment. So capacity for some type of employment, not suitable duties. So suitable employment is based on the patient's age, the patient's skill, and the patient's education. So for example, a bricklayer who only knows bricklaying and that's all he's done for all of his life, injures his back. Now, his capacity for activities will say, let's say, for example, he can lift 5 kilograms, he can sit and stand for an hour, he can drive for an hour. Hey, he has capacity for activities because therefore he's fit for suitable duties. Not necessarily, because a bricklayer can only lay bricks. That he doesn't know, his mental capacity doesn't allow him to do anything else. But he does have the capacity to work in an office. But again, that's not suitable in regards to his age, his education, and his level of skill.
So it's suitable employment, not suitable duties.
Correct. So the terminology rehab consultants use was suitable duties, but the certificate says capacity for some type of work And Section 32A talks of suitable employment.
Oh, that's cool.
Yeah, so whether they can or cannot be employed. So anyone, even if you're in a wheelchair, you have capacity for some type of work.
Yep.
You can do something, but are you eligible, or do they have the capacity to work based on their level of education and then skill? So that's the biggest, I guess, issues that I have working as an NTD, trying to explain to, I guess, insurers and everyone else understanding what that actually means.
What's the common confusion with that part then? Like, I'm assuming, super duties is one part of it, meaning, people are saying, hey, this guy can sit down, therefore, he can drive a car or some shit, like,
correct,
something like that,
sure.
right? And like, what's the common argument that, I guess insurers will put forward?
Well, I would have insurers ask me as an IMC or even as an NTD, the patient has the capacity to lift 5 kilograms. He has capacity to sit and stand for 20 minutes. So therefore he has capacity for some type of work. Again, not necessarily. A bricklayer doesn't have that level of education, doesn't have that level of skill. So this is why rehab providers are so important, because we require the rehab consultants to assess the patient, to do their initial assessment, to determine what they can and cannot do at the workplace based on their current level of skill and current level of education.
And I guess, what your job is, it's to match the skills that I have with proper employment, not
Correct.
just any employment.
Correct. Oh, they can do any employment as long as it's within their level of skill. So a bricklayer cannot work as a receptionist. He may not have the mental capacity to do that. It may take him a very long time to teach him on computer work, keying and typing. So it may not be feasible.
Then what makes you determine whether he can or cannot do that, or is it circumstantial based?
No, again, what determines what I write on a certificate of capacity is based on what the patient can or cannot do physically, and also from a mental perspective in regards to, does he have that skill to do that? So anyone can perform very light work. Anyone can perform my job. It's just literally keying and mousing. But do they have the mental capacity to do my job? They cannot. So they can't work as a doctor, even though the work is sedentary. Although they physically can have the capacity to do that, they cannot have the mental capacity to do that. And I guess that's the biggest misnomer. People keep thinking if you have physical capacity, therefore you have capacity for some type of employment, and that's not true.
Oh, that's good. Thank you for the explanation. Because I think a lot of people are confused about that specific term, and we get a lot of points of contention with that. Like, there's a lot of arguments back and forth saying he can do this work, he can't do this work, therefore
yeah,
all that stuff.
I believe in the past 30 years of me working in this space, I do not believe I've had one single rehab consultant come to me to state that based on the patient's current level of skill, let's say, for example, he finished year 12 or he finished university, that based on the physical capacity, he has the capacity to work as this, and that. Yeah. So I guess there's a lot of education in the rehab consultant's sense as well.
Hey, no, I need to teach my guys. Like, if my guys are watching this, make sure you'll actually go and read the section 53.
Section 32A.
32A, sorry. And familiarize yourself with it so that you can go up to Dr. Tang and say, hey, I want an upgrade. Okay, all right. Down the list, we're on capacity. What else do you look for as an IMC?
Guess what? The base is to see what issues we have, what disputes we have. It's not one specific thing we look at. It's the certificates that I just mentioned. What I look at there. Yep. Then when I speak to the treating doctor, then I understand. So I need to have a verbal dialogue with the treating doctors. Unfortunately, one of my barriers is that the treating doctors refuse to speak to me. They all say, "Send me an email." The legislation stipulates that as a treating doctor, you must participate in an active dialogue with an IMC. And again, most treating doctors may not know that, and they never return my calls.
Well, active dialogue, email is not an active dialogue?
No, it's basically a verbal discussion, because it makes it a lot easier. It's very difficult for me to ask a question. They come back with an answer, then I have to write back to them again. So I almost always try to speak to the treating doctor.
What happens if they don't answer you then?
Well, the standards stipulate as an IMC, we need to contact the treating doctor at least 3 times.
3 times.
3 times. So I try to do 10 times if I believe that I can get to speak to the treating doctors, because speaking to a treating doctor, having an active dialogue would trump any emails. So pending that, if the treating doctor declines to speak to me, then I ask to ensure that I actually see the patient physically myself and try to sort out the issue myself when I speak to when I see the patient face to face or via telehealth with an examination.
So you essentially just kick the NTD off. Is that what happens?
Well, if the NTD is a barrier, then there's no other way of communicating with the NTD, because again, the insurers. Usually, well, the insurers, the most common reason why insurers refer to me is because the NTD refuses to speak to the insurer, and then when they refuse to speak to the insurer, most of the times they refuse to speak to me.
Why is that? Like, why is it that doctors just can't communicate?
I don't know. Maybe they're quite busy, and again, this goes back again to either a work cover to treating doctor or a non-work cover treating doctor, because I allocate a lot of my time doing administrative work. Hence, I wake up at 7:30 and I'm here doing admin work even prior to seeing patients, because the administrative burden for a treating doctor is quite onerous.
Wow. Okay. Cool. That's pretty damn cool. And say IMC, you somehow found the doctor being the barrier, and then you somehow overcome it. What happens then?
Well, then hopefully the rehab consultants will come in and they'll use my report, and they'll hopefully negotiate with the treating doctor to either get an upgrade, to change the treatment, because if the treatment's not working, then we need to do something. There's something else present, and hopefully with that tool they can get the patient back to full duties and have the case closed.
And then that's the end of the intervention of an IMC.
Correct. So my role is purely, like I said, is to facilitate and to assist the injured worker as much as possible.
So essentially it sounds like just education, and then negotiations and mediations.
Yeah, the most of my role is just purely to educate everyone around about the scheme, what they can and cannot access, and what they can and cannot do, and what they can do to help the insurance company approve their services.
Can you go back, go into memory and remember one of the most difficult doctors that you've ever dealt with, and a story behind that? Tell us a story.
There's a lot, I guess, but the biggest difficulty I have with doctors is when they don't return my calls or they refuse to return my calls. There's nothing I can do about that. And also some doctors, when I do talk to them, I did have one doctor where I try to explain to them, your diagnosis is not a diagnosis. Like, for example, back pain is not.
Okay, can we go in specifics, slightly more specific into the example?
Okay, well, I use back pain as an example. So I'll have a patient. The diagnosis will be back pain, and I try to ask the doctor, can we please clarify on the correct diagnosis as per the work-related injury, and the treating doctor is very insistent on back pain, saying that that's a diagnosis. I'm not giving anything else. When I try to explain further, they get very angry, and they get I guess very defensive, and they refuse to talk any further because they believe that I'm trying to educate them in regards to the medicine. I'm not. I can't make a diagnosis without physically seeing the patient, but I do know that you can't just put back pain. So I try to elaborate. I try to ask the doctor, what else could it be? But can you please provide the diagnosis based on the work-related injury? So unfortunately, this particular doctor was very, very, very defensive and refused to speak and literally hung up on me. And there's nothing much else we can do. And the problem also is I believe the treating doctors need to understand is that if they're the barrier, then their patients suffer, because then the patient are denied services, denied approval for whatever services the treating doctor needs.
Okay. No, I get it, because I see that quite a bit as well. Like sending emails and then it just goes into a well, never replies, nothing like that. That's not all doctors, just some doctors, some old school doctors, I think.
Correct.
Yeah.
Well, that's my job as an IMC. But unfortunately, when I speak to them, the reason why I get a referral is because they're being difficult. Yeah. If they're not being difficult, then I don't get referrals.
Absolutely. All right. No, enough about talking bad about doctors.
Oh no, I'm not talking good. I don't know. We never say that. The doctors are very busy, and we understand. We understand that the reason why they do what they do is most likely because they're very busy, and
yes,
and they just don't have the time.
Yeah, that's true. All right. Then I guess let's move on to another topic, which is insurance companies, because I do know that, there are a lot of points of contention between, insurers and doctors as well, normally. Like, what are some of the common ones that you see?
Well, the biggest bugbear I have with, I guess, the claims process is around payment. So for the treating doctors out there, there's a thing again called standards of practice 10.1. Maybe it's 11. I can't remember. Actually, no, it is 10. It is 10.1. Talks about payment of the invoices. Mm-hmm. The insurance company needs to pay our invoices as treating doctors, or even as an IMC, within 10 working days of an accepted tax invoice. Now, if the invoice is accepted and if the invoice is correct, they need to pay within those 10 working days. If they don't, they need to actually write to the treating doctors to explain why. Unfortunately, the compliance rate of that is actually very, very low. So I would perceive at least there's a 20% compliance rate. So we rarely...
20%?
Yeah, we rarely get emails saying that we're not paying you this invoice within 10 working days. And I guess this is another reason why a lot of treating doctors don't like work cover, because they don't get paid and they're disgruntled and they don't get any information in regards to why don't they get paid. That's the biggest contention I have with insurers, because if they don't pay, when we have,
what are we doing? Yeah.
And when we have invoices that's months to even years outstanding.
I actually have a story on that as well. Like, we have an outstanding invoice for maybe like 2 or 3 years. But the funny thing is, actually, there's two stories. One is an invoice for 2 or 3 years. The only reason we're getting paid is because they've accidentally paid to someone else. And I'm like, dude, that's not my problem. My bank account details are there. You've got I think it's like F-Sure that's doing all the authorization, making sure the bank account numbers are correct and all that stuff. But they paid to someone else, and they're coming back to us and saying, because we paid to someone else, we can't pay you. I'm like,
that's not your.
How is that my problem?
That's not.
But like, they're insisting that they won't pay me until somehow they recover the fees, which is
not
insane.
Correct.
Which is insane, and that's been 3 years. Yeah, and there's another one. I think it's a very famous company that within our industry. I won't name them, but what they do is they will try to make sure that they don't pay. Pretty much pick on every single invoice and make sure they don't pay it. And I think I got a decent amount owing from that company. It's one of those like subcontracted claims.
I think I know what you're talking about, and that happens with us as well. They just refuse to pay, and unfortunately, it may save the money again, but it's detrimental to everyone on the long run. Treating doctors will refuse to see work cover patients.
Correct.
Treating doctors, I guess, would unfortunately charge patients, which is not allowed, but they still do because they want to get paid, and I understand. But again, like I said, it's detrimental to the injured worker
process.
as a whole.
Yeah, because like essentially right now we're saying basically any claims with that specific company, we just won't do it because what's the point of doing work without getting paid?
It's very unfortunate that happens.
Yeah. In terms of payments is one thing. What other
Well, in regards to insurers, I guess the biggest issue I have is also in regards to education to the case officers. Okay. I get a lot of emails from case officers citing wrong information.
That's common.
Yeah, it's so common. So I mean, my biggest contention will be an IME. So my biggest contention is that if the case officer has an issue, they'll refer a patient to an IME. So an IME stands for independent medical examiner. Yep. But unfortunately,
there's criteria, right? There's criteria you need to meet before you return.
Yeah. So a lot of case officers are not aware. I've spoken to a lot of them, and a few of them actually informed me that they were never trained in this.
What's a lot?
So the people that I speak to, probably about over 95% are not aware of the actual standards, which is that's from my personal view.
And you speak to a lot of case officers.
I speak to a lot of case officers. So there's a thing called Section 7.1, also Part 7.1 of the Workers' Compensation Guidelines. So Part 7.1, if I remember specifically, is that a referral to an IME can only occur if the information provided by the nominee treating doctor is inadequate, unavailable, or inconsistent, despite multiple requests from the insurer to resolve the disputes. So what that means is the insurance company needs to at least make attempts to speak to us, an email or treating doctor, to send an email, to send a follow-up email, and then to make numerous phone calls to say, hey, listen, can we please have this information? We wrote an email. Can you please respond to the report? This rarely happens. And even when we do write the report, the insurance company needs to actually come back to us and say, hey, listen, we don't agree with point 1 and point 3. Can you please elaborate? I can tell you anecdotally, this has never happened. So what
never happened?
Never happened. So the insurance company has never come back to me and say, hey, listen, thank you for your report. We disagree with point 1 and point 3. Can you please elaborate? And then if we elaborate, they still don't agree, they still need to come back to us and say, hey, listen, we don't agree with point 1 and point 3, your response. Hence, no, we're going to refer to an IME. So unfortunately, I find for me as an NTD that insurance companies make a lot of IME referrals and a substantial amount in breach of the standards of Part 7.1.
Well, what are the consequences for, patients when, IMEs are used like that?
Well, the purpose of IME is to basically assist the insurers with the claim. Whether that to assist with a diagnosis or whether to assist with treatment or even to assist with liability. But prior to that, they still need to follow the standards prior to referring, because they need to speak to the treating doctor first. So, hey, listen, you left the diagnosis blank. Look, I'm sorry. The diagnosis is, let's say, major depressive disorder with anxious distress. And this is the mechanism of injury. They need to first communicate with the treating doctors. Unfortunately, this has rarely happened. Unfortunately, a few outcomes that can happen if a patient sees an IME. So if this patient sees an IME purely for the purposes of not doing what they call a whole person impairment, the IME can either close the case, so have the case can be the insurance company can literally decline the case based on the IME report, or they can deny treatment or accept treatment. So again, anecdotally, I find the insurance company refer to an IME because it's easy, and they'll bypass the treating doctor, which they can't do. They need to speak to the treating doctor first, and that's the contentions that I have as a treating doctor, because they rarely even speak to me to find out what's going on, what issues they have, such that we can try to resolve these issues.
It sounds like to me that because most doctors, NTDs, don't reply, therefore they just essentially rely on people not replying to emails and saying that the doctors are not responsive, and therefore let's go IME everything.
They can do that, but Part 7.1 also states that they need to have evidence on file, multiple evidence of contact. Now, again, I can only speak for myself anecdotally and my team. I've had IME referrals based on information that the insurance company sent me. So they'll send me a list of questions to respond to. Let's say, for example, they sent it today at 10 o'clock, and by 12 p.m., they'll send my patient a letter saying that we're referring to an IME.
No way.
Yes. So this is actually quite common. And then when you ask the insurer, they will say that my report was inconsistent, unavailable, or inadequate. But then they'll say, hey, listen,
3 hours.
You gave me 2 hours to respond. But on your report, you stated, on your report request, you stated that I have 10 working days. So unfortunately, some case officers actually do that. But again, anecdotally, I find that there's a lot.
But you're saying that it might be just down to a lack of training for these case officers.
Yeah, because I've seen a lot of letters. So before an insurer refers to an IME, they need to send out a letter to a patient. So the injured worker, they need to explain the reasons why. Yep. Now, I'm quoting standards again and the legislation. So Part 7.5 stipulates that the information provided by the insurer, and it says must contain the reason why the treating doctor's report is unavailable, inconsistent, or inadequate. Now, that's a must. Now, 100% of the letters that I receive from my patients does not stipulate that. It's a basic template which tells me that all they do is that they use a template.
Just copy and paste.
It's just a copy and paste template. And all it says is, from memory, it says, we're referring to an IME purely because, we need further information. Or we're referring you to a whole person impairment. Whole person impairment can only perform at least 12 months after the injury. But yeah, so it's 100%, it's a standardized template. So that's how I know that the insurers haven't actually followed the standards, and they refer to the IME anyway. They threaten the patients with attendance, because if they say if you don't go, I think it's section 116A, I think it is, that they'll withdraw wages if they don't attend.
So they threaten them and say, if you don't go, this is going to happen. But they're also essentially breaking the rules by referring them to IME.
Without speaking to the treating doctor, without raising disputes, without trying to resolve the issues with the NTD. I find, unfortunately, it seems the case of us are trying to bypass treating doctors and not talk to us altogether. Again, that's actually in breach of the standards. I can quote you, there was a study done by CIRA in May 2025. It was only actually for 5 days. It was done against QBE for 5 working days and on 50 patients. I can quote Appendix 9, Part 43. Again, it's about 40 something. The compliance rate was 66.7% in regards to Part 7.1, which means that QBE complied 66.7% of the times by making a correct referral, because what they're saying is that the information from the treating doctor is inconsistent, unavailable, inadequate, despite numerous attempts. I can also say that the compliance rate was 0% for notifying a nominee treating doctor within 5 working days of an IMC referral. So again, anecdotally, for my experience, the compliance rate for myself in regards to an IME referral is probably less than 5%.
No way.
Yeah, and the 0% for an IMC, I can attest to that. That's correct, because I have never received a letter from an insurer stating that they refer my patient to an IMC within 5 working days of the referral.
Well, say, they don't do that, like non-compliance. What are the I guess, is this something the patient's going to do? Because I guess, all these rules are there to make sure the system is fair, right?
Correct.
So what can a patient do to essentially overturn it, or,
They can first write to the insurer, and I encourage patients that actually get this to write to the insurer and ask them, hey, listen, your letter you sent me is a standard template. But unfortunately, most patients don't realize it's a standard template. They don't realize what it needs to contain. And to ask the insurer, why are you referring? What's the reasoning? You tell me why you're referring me to an IME, so I can actually work out. It's not the patient's responsibility to work out if they follow the standards or not. But it's very stressful for a patient. They don't understand what's going on. They may refer to Dr. X. They'll Google Dr. X, and Dr. X has all these bad reviews. So therefore, they're terrified. I don't want to go to Dr. X. I know I'm going to get a bad report. So that raises significant anxiety. But yeah, so look, for inappropriate referrals from insurers, the only recourse the patient actually has is they need to make a complaint to the IRO after speaking to the insurer.
And what are some of the consequences if they don't do that?
Well, again, the insurers inform the patients that if you do not attend, then they can withhold their wages. And patients need their wages. They can't survive. Most patients can't survive more than a week without their wages. So they're petrified. So with they're petrified, they attend. Yeah, they attend.
Oh, wow, that's crazy. No, this is somewhat new to me, because I'm not particularly well versed in the IMC IME world, unlike you, and no, I actually didn't know a bunch of this information.
Yeah, look, I got into this when my claims are getting declined. So all the claims get declined after the IME.
Is this going back like 20 years ago or something?
Yeah.
Okay.
Well, over the past 20 or 30 odd years, when the claims are getting declined by the insurers, the patients are left with nothing. They end up losing their wages, and then they have to fight it with their solicitors. Yep. Unfortunately, the process in regard getting it overturned can take months to, if not years. I mean, I've had a patient without wages, for over 12 months and no treatment to get their cases overturned.
And if it's a legitimate claim, legitimate everything, and then all they did was, decline it.
Yes.
Essentially, they have to back pay everything.
Yes. Well, again, I'm not familiar with that type of law, but I do know that if the cases get overturned, most of my cases that are declined are overturned by solicitors, and I would say a large proportion, over 95% of my cases, get overturned. So at most times I don't see the point of the IME because they decline the case. Solicitors come in, they overturn the case, but unfortunately my patients suffer. So 12 months, up to 12 months of no wages, no treatment.
No treatment. That's actually very bad for patients. Yeah, very bad.
Yeah, so
and that's usually a prime time for them to get some sort of recovery.
Correct. Yeah, correct. So it delays recovery significantly.
You mentioned something. 95% of your patients get overturned by lawyers.
Mm-hmm.
What does that mean? Like,
well, again, this is based on my experience. So based on my experience, it seems that the IME was incorrect.
So IME goes and says, this person, that the claim's not legitimate, decline.
Or not legitimate. It's a legitimate claim, but it doesn't pass the work-related injury test. Yep. I screen all my patients. So all my patients that I see that I provide a certificate basically pass the test. If they do not have a workload injury, I would not issue them with a certificate of capacity. I would decline probably about 3 or 4% of the cases that I see because they do not have a work-related injury.
Okay, and then when that happens, essentially the lawyers would go and do some of their IMEs. I'm
Correct.
assuming.
So yeah.
And then what happens then? Like, do they the two reports?
I guess that will be a question for a lawyer. I guess you can do a YouTube podcast for the lawyers to ask the lawyers in regards to what they do in that case. But what the lawyers usually do is they'll send the injured worker to another IME. This is funded by the Independent Review Office. Yep. The IME then will assess the case and make a determination if it is related to work or it's not related to work. So if it's related to work, then they'll take it to the commission and they'll have that overturned.
Oh, is that why it takes so long? Because once it goes into a commission, like a tribunal, whatever it is,
it does take a long time. Again, I can only tell you from my experience, it can take it will take months. It will not weeks. It's definitely months, and I've had up to 12 months for my patients.
Okay, well, that's a lot of information that our audience can learn from. But I guess we are going up to an hour, so let's wrap it up. But one question that I do really want to ask: what's the most gruesome injury that you've seen at a workplace, and what is one of the a funny injury that you've seen, like as in like an injury that shouldn't have happened that happened?
Well, the most gruesome I've seen is death. Unfortunately, the patients passed away. That's the saddest and that's the most severe injuries I've seen. I guess a severe injury that doesn't involve death is I've had a patient literally fully amputated their right hand at the age of 21 years of age, and that's so unfortunate. 21 years at the prime of his life, and he's lost his right hand, and he was right-handed.
Wow.
Funny injuries. I don't have, and I can't think of anything at the moment with funny injuries. There are that I have had so many cases, but I can't mention the severe ones. I can't remember any funny injuries. But
what are some of the other severe ones that you've seen then?
I guess chainsaw accidents with kickbacks. Yeah,
okay.
Yeah. They basically literally the chainsaw kickbacked and literally cut half their shoulder off.
Shoulder,
yeah, kickback. It's chainsaw kickback. So,
wow.
So they're preventable, or I guess it's mainly preventable injuries. I've had patients fall off a tree. I've had an arborist fall off. I think it's like 20 meters off a tree, landed and snapped his leg right open.
But he survived.
Oh, he survived. Yeah.
Wow.
But it's very traumatic because they're very young, and this poor guy can't walk because he's had such a severe injury. So that's why I see my role is very important, because we need to help these patients recover to the best they can.
If an injured worker gets injured and they want to find you, how can they find you?
Look, they can look me up online. They can search my name, Dr. Danny Tang, or Patrick Street Medical Centre, or they can call 02-8814-8813, or they can also just search our website, www.ausrehab.com. www.patrickmedical.com.au.
With that, I think, thank you for your time. And I've learned a lot. I hope that our audience has learned a lot. If you liked it, comment and subscribe, and follow Dr. Tang as well.
Thank you for the invite.